Good morning, everyone. It is my distinct honor to be able to introduce this morning Cissy Kityo. For those of you who don't know me, I am Serena Koenig. I'm one of um, the people who work on organizing the Global Health Grand Rounds, and along with Joe and Amir and Louise. Cissy Kityo is a force and has been a force for many, many years in the treatment of HIV in international sites. And I think it's just a real pleasure that we get to have your time, Cissy, this morning to get to hear some of your insights, especially during these really challenging times. So, for those of you who do not know Cissy, she's the executive director of the Joint Clinical Research Center in Uganda. She's also the International Vice Chair of the Advancing Clinical Trials Globally, or the ACTG. She has degrees in medicine and a master's degree and a PhD, and is a public health specialist and epidemiologist with over 30 years of experience in HIV care, treatment, and research. She's a pioneer of initial use of ART in sub-Saharan Africa from 1992. So Cissy has certainly seen the growth and now the challenges in HIV treatment. She's been at the forefront of scaling up care and treatment since 2003. She has overseen USAID and PEPFAR funded projects to scale up HIV treatment and strengthen health systems for the delivery of care for the last 20 years. She has been PI, co PI, or investigator for over 100 research projects, many of them pioneering research that has informed policy and clinical practice in Uganda and other low and middle income countries. Most relevant for today, she is the chief investigator for the CARES trial, which was the first trial of long acting ART in Africa, and it included 8 sites in 3 countries. She's also working towards pioneer gene therapy for HIV cure in Africa. She co-founded the Global Gene Therapy Initiative and with over 100 experts to support bridging the existing gaps and implement gene therapy research as well for eventual access. So, Cissy, we are really thrilled to have you and thank you when you're so busy for taking this time to present to us this morning.
Thank you, Serena, for the elaborate introduction. I would like to thank the organizers of this grand round for inviting me to talk about long-acting antiretroviral therapy in low and middle-income countries. Next slide. These are my disclosures. Next slide. So, as Serena introduced, I've been working in this field of HIV for many years. And we have seen, and others maybe possibly on this call, how HIV treatment has evolved to address the needs of people with HIV beyond viral suppression. We initially had many tablets taken many times a day. This has evolved to fix those combinations, to and within this, we are also seeing now simplification to drug combinations, again, in fixed dose combinations, but very interestingly also long-acting therapy, which is now the frontier of HIV treatment. And this is mainly, this simplification is looking at increasing or improving patient outcomes and more engagement of patients in care, and also adding to quality of life. So it's not just viral suppression, but we are going beyond viral suppression to make experience of patients much better. Next slide. Next slide. So these studies Some of you may have heard already about them. These were efficacy studies of long-acting ART using two drugs, cabotegravir and rilpivirine, and these have demonstrated, these are phase 3 clinical trials, FLAIR, ATLAS, and then ATLAS 2M. These have established non-inferiority of long-acting therapy using two combination drugs compared with daily HIV regimens, and also shown that every 2-month dosing is non-inferior to monthly dosing. So again, the results of these studies were very exciting in the field of HIV treatment. Next slide. So based on these registration trials, we now have guidelines, we have recommendations to use cabotegravir and rilpivirine as a strategy to improve treatment satisfaction and quality of life. European guidelines, USA guidelines, THS guidelines, all recommend, at least for now, or initially, to use cabotegravir and rilpivirine as a switch option for biologically suppressed people with HIV. But also these guidelines realize that injectable cabotegravir and rilpivirine increases convenience of reduced dosing frequency and also improves quality of life. So these guidelines are available for high-income countries, and rollout and implementation of injectables has started in these countries. Next slide. We do realize that people with HIV still have unmet needs and unfulfilled treatment aspirations. And this is universal. It's not just for high-income countries. And as you can see, can you go on with this slide? Just go on. There are many unmet needs, including frequency of dosing. We have fixed dose combinations, but we have to take daily or ART. There is pill fatigue. There is unmet need of convenience. There are also psychological challenges. And so now, for the first time, we have the first and only complete long-acting HIV treatment regimen using cabotegravir and rilpivirine, which can be given every 2 months. And we know that this may also improve patient engagement via scheduled clinic visits. But again, these unmet needs are universal, but now long-acting antiretroviral therapy is only available and in guidelines for high-income countries. Next slide. So these registration trials were done in those countries shown there. The only country that was included in sub-Saharan Africa was South Africa, with a few participants. But the population in high-income countries is certainly not generalizable to low and middle-income settings, where we do use a public health approach. So the question was, at the time we thought about doing a trial in sub-Saharan Africa, is whether we needed additional evidence to determine the role of long-acting therapy in treatment programs with a public health approach in sub-Saharan Africa, as one of the continents in one middle-income countries, but also with the biggest brand or biggest burden of HIV in the world. Next slide. So there are many differences between the populations, and that is why we needed to repeat a study in this population. The presence of occult resistance to NNRTIs from prior episodes of undetected treatment failure and use of nevirapine for prevention of mother-to-child transmission is fairly high. The viral subtypes are different. Comorbidities are different, especially TB, which is fairly common and which requires concomitant medications to be taken with available antiretroviral drugs. ART regimens used in the standard of care arm is now mainly TLD, which is tenofovir, lamivudine, and dolutegravir. And these are different again for high-income countries. And most of the population affected in sub-Saharan Africa are Black African women. And then care and treatment strategies are different. We have infrequent viral load and safety monitoring. So everything is different, and we could not just translate the results from high-income countries to our populations. Next slide. So in 2020, we did craft this study, which is a randomized trial of cabotegravir and rilpivirine, long-acting in Africa, called CARES. And the study hypothesis was that dual long-acting injectable ART with carb and rilpivirine is non-inferior in the proportion of participants with plasma HIV RNA below 50 copies at month 12 compared to daily triple oral current antiretroviral regimens consisting of either an INSTI or NNRTI with a backbone of tenofovir or 3TC and all FTC regimen. Next slide. So this was the primary objective of this study, was to demonstrate the antiviral and immunologic activity of switching to injectable cabotegravir and rilpivirine every 2 months compared to continuation of combination ART over 12 and 24 months of follow-up. There were several secondary objectives, which I'll talk about briefly in the results. Next slide. So this was the study design. This was a phase 3B randomized, open-label, active controlled, multi-center parallel group non-inferiority study. We recruited participants who were adults above 18 years of age. They were stable on stable oral therapy, including either tenofovir, 3TC, or FTC, with dolutegravir, nevirapine, or efavirenz. They had to be virologically suppressed with no history of treatment failure and no hepatitis B infection. They were randomized to either stay on their oral ART or switch to the injectable arm. And there was an optional oral lead-in of cabotegravir and rilpivirine. And this was explained very clearly to the patients. Next slide. So, no, back, no. Can we go back? Go back. Go back. Yeah, here. No. Oh. Go forward. Go forward. There. No. Go back one slide, please. Ooh. One slide. Go back. Yes, here. There is animation. Oh. Okay. There. Just stay there. Okay. So we did do viral loads every 24 weeks. This is very different from what you do in high income countries. And this was to sort of mirror what we do in our practice. Usually we do a viral load once every year in general care. We did take samples at baseline to do retrospectively look at the HIV subtype, but also look at archived resistance in this population. Next slide. There. So the primary endpoint was at week 48, as shown in the previous slide, and this was the enrollment and retention. We recruited participants, a total of 512 participants across 3 countries. As can be shown on the slide, that was Uganda, Kenya, and South Africa. And at the end of week 48, we had an excellent retention of 99% of the participants that we enrolled. Next slide. So these were the baseline characteristics. As expected, we had more females. People had been on treatment for a median of 8 years, and most of them had been switched because from 2018 we started recruiting at the end of 2021, and most of the participants in low and middle income, at least in sub-Saharan Africa, had switched to TLD. So 92% of the participants were on TLD when we started enrolling, but 74% had had exposure to NNRTIs. Next slide. Yeah, stay there. So can you go back? Yes. So we had, this is a summary of the retrospective sequencing that we did from the PBMCs we took at baseline. We had the majority of the participants, 55%, had viral subtype A1. And then we had existing reprievrin resistance was 8%, fairly high. And also resistance to cabotegravir was 11.3%. And this was after we had removed any mutations that were ApoBec related, because we know that those mutations that are ApoBec related will not translate into actual resistance when patients are on treatment. Next slide. So these are the results at week 48. You can see those bars in red and gray. We had very similar viral suppression, which was the primary outcome, below 50 copies. So we didn't see any difference between the 2 arms. Next slide. Next slide. And when we look at the intention to treat analysis, the adjusted difference was minus 0.5. This fell within the non-inferiority margin, which we had set at 10%. And so the results showed, or they met the non-inferiority criterion that we set at the beginning. We also looked at sensitivity analysis at using the protocol adjusted difference, and then this again confirmed non-inferiority. Next slide. So we have already published the 48 weeks results, and but we continue to follow the participants up to week 96, and we wanted to demonstrate the sustained virologic response and safety of switching virologically suppressed adults to cabotegravir and reprievrin every 8 weeks compared to continuing oral standard of care in sub-Saharan African population managed under a public health approach at week 96. Next slide. So again, that was the design. We continued following up these participants up to week 96. And last year, we completed the follow-up of all the participants that were still in follow-up. Next slide. Next. Again. Next. Next. Yeah. So we had back. Again, like at week 48, we had 98% retention of the participants by week 96. The per protocol analysis had fewer participants because of people who missed their injections within the 7-day window, or people who missed their oral doses, and people who relocated. Yeah, next slide. So this is the adherence and timing of injections. We had 81% of participants receiving all scheduled injections within the protocol mandated 7-day window. Next slide. Next. Yeah. So as you can see, of the expected scheduled injections, 97% were received within the window, and which was the 7-day window. And we only had a few outliers injections that happened outside of the 7-day window. Next slide. Again, these are the results at week 96, intention to treat. If you look at the blue bar and the gray bar, exactly similar results. Primary outcome proportion with plasma RNA below 50 copies was similar between the two groups. Next slide. When you look at the main analysis, which is intention to treat, again, the results confirmed the non-inferiority criterion which we had set at the outset of this trial. Next. So we had some biologic failures in the study. There were a total of 4. All of them were in the long-acting arm, but the difference was not statistically significant, as you can see. Next slide. So we had 4 participants who failed. One of them died soon after week 48, participant 2. And they did not die from intervention, but they had a post-surgical complication. And so those are the viral loads at which these participants failed. And all of them had reprievin mutations at the time of failure, except for participant number 3, where we could not, the sequencing failed. And then they also had cabotegravir mutations. Next slide. We looked at the baseline, some of the factors that have been shown to predict failure. And we see that of the 4 participants, only 2, which is 50%, had reprievin baseline mutations, which has been shown to be a predictor. And the viral subtype is, we have 50% that have A1. And then for the BMI, none of the participants who failed had BMI. Next slide. At the safety at week 96, and we found that grade 3 or more adverse events were higher in the long-acting arm, but those related to study drug were very similar across the sites. And on that slide, you can see the details of the adverse events that we saw in the 2 groups. Only those that led to study drug discontinuation, again, were similar between the groups. Next slide. Injection site reactions, as expected, was fairly frequent, and the most frequent one was pain. But most of these were grade 1 or 2, and we only had 1 grade 3. None were grade 4. There was only 1 injection site sterile abscess that led to treatment discontinuation in this group. Next slide. So we looked at treatment satisfaction and preference in CARES at week 96, and we did assess this using the HIV treatment satisfaction questionnaire, change version. We found that treatment satisfaction increased to a greater extent in participants who switched to carb and reprievering versus those who continued on oral ART at week 96. When we asked participants, 244, at the end of the trial, over 99% on long-acting, preferred long-acting therapy over daily oral treatment at week 96. Next slide. Next slide. Yes, so as you can see on this slide, the cares of sub-Saharan African patients on long-acting are not alone. These questions have been asked to many other participants in high-income countries in clinical trials and real-world evidence trials. And over 90% of people living with HIV preferred cabotegravir plus reprievring. Next slide. Again, treatment satisfaction has been seen across many sites. So long-acting treatment, again, is good for high-income countries and also good for low and middle-income countries. And there are many reasons that people prefer long-acting in terms of lifestyle fit, wish to continue on injectables, and then also convenience. Although they may have to come back to the clinic every 2 months instead of longer periods of time that oral therapy may be given 3 or 6 months, many patients still choose to have the injectable. Next slide. So in conclusion, at week 96, cabotegravir and reprievring, long-acting given every 8 weeks in sub-Saharan Africa had high efficacy. 97% had viral suppression, below 50 copies. We had 1.6 had confirmed virologic failure. And these 3, because one died soon after, these 3 resuppressed after switch to tenofovir, lamivudine, and dolutegravir, which was available in the clinic. So all these achievements were made in the public health approach with sparse viral load monitoring, and despite populations with high rates of obesity, which was about 21% at baseline, and also prior NNRTI exposure and reprievring resistance mutations, and also different subtypes. Majority, which was A1, at 55%. Next slide. And next. And next. So there was good safety profile, and long-acting was well tolerated. We only had 2% that had severe, which is grade 3 or above adverse events related to study medications. We had 5% serious adverse events. Injection site reactions were mainly grade 1 or 2, only 1 leading to discontinuation. There was increased treatment satisfaction and preference for patients to stay on cabotegravir and reprievring. So the overall conclusion here is that this demonstration of safety and efficacy of cabotegravir and reprievring in extended follow-up up to week 96 is an essential first step to discussing a potential role for long-acting in treatment programs in sub-Saharan Africa using the public health approach. Next slide. I would like to, of course, acknowledge many people that contributed to these results, both week 48 and week 96 in the CARES trial. Next slide. In particular, we worked with Nick Payton, who was our scientific lead, And we also worked with Ivan, who was the project manager. Next slide. Next slide. Yeah. So this slide just puts in context the results of care after follow-up of 2 years and the other studies that have been done in high-income countries. Some are clinical trials and others are real-world evidence. The virologic suppression is very comparable, and we might say a bit higher in the cares. Confirmed virologic failure rates are also comparable to other studies. And failures, of course, what we saw in cares is that patients who failed with resistance mutations. But I think this is what we wanted to show whether there was any difference, and we see that we had comparable results in populations that are completely different from those in sub-Saharan Africa. Next slide. So, and we got those results irrespective of the pre-existing NNRTI resistance with Reprievrin RAMS. This graph on the right-hand side is from WHO report in 2024. And the rates in some countries are fairly high. But there is also been worries or issues about Reprievrin. It has a lower genetic barrier to resistance compared to dolutegravir, for example, but also because it has a cold chain requirement. But this is what our results showed. Even if we wanted to, even if WHO adopted cabotegravir and Reprievrin today for the national guidelines to guide us, for WHO guidelines to guide national guidelines, there is a challenge to global access to Reprievrin. I think Janssen, which is supposed to supply or distribute Reprievrin and cabotegravir in low and middle income countries, has pulled out. And so even if we wanted to use cabotegravir and Reprievrin today, we are not able to access it for our populations. Next slide. Next slide. Yeah. So, and again, the guidelines have now changed. Initially, cabotegravir and Reprievrin was mainly for virologically suppressed. There has been some demonstration projects, some small trials that have shown that long-acting ART is doing well in especially patients who have adherence challenges and also have viremia. And so now cabotegravir and Reprievrin have been included in the guidelines for use in this category of patients. Next slide. And these are just a few of those demonstration projects that have shown long-acting cabotegravir and Reprievrin, and some of them have actually also added lenacapavir, that these long-acting combinations are working well in patients who are viremic. Next slide. Go on. So for these are the UNAIDS targets, and for 2025, including all these 95, 95, 95 targets. One of the targets, the last 95, is people with HIV on treatment with suppressed viral loads. And one of the main areas where long-acting ART may help in terms of enhancing adherence and suppressing viral loads is this 95. But I think it is agreed that there is a fourth 90, which is ensuring the long-term well-being of people with HIV, improving quality of life, stigma and discrimination. And so long-acting ART is seen as one of the interventions that may address some of these key unmet needs to improve quality of life and also support the UNAIDS goals. But again, long-acting, the unmet needs are universal. They are not just in high-income countries, and we need to see how to address them as well in low and middle-income countries. Next slide. So as part of this drive to see how we can improve equity and also provide access to long-acting in low and middle-income countries, as a follow-on to CARES within the ACTG, we are in the process of designing a trial for international sites outside of the US to evaluate long-acting lenacapavir and cabotegravir efficacy and safety, also called the Lancet trial. Next slide. So the justification for this, besides cabotegravir and reprievin, which we can't have access to, the next most promising potential medium-term combination is cabotegravir and reprievin. Lenacapavir and cabotegravir. Lenacapavir is given every 6 months. Cabotegravir is given every 2 months. But we know that VIV is working on a 4-monthly regimen for cabotegravir. We also need to promote equity and enable access to innovative long-acting drugs in low and middle-income countries. Long-acting injectable combinations has the potential to enhance ART delivery and support achieving widespread viral suppression, which is one of the third 95 targets of UNAIDS. We've already discussed with VIV and Gilead. They will donate drug for the trial, and they will also donate drug for a US-based trial using lenacapavir and cabotegravir. And we've already seen that long-acting cabotegravir and reprievin has been shown to be superior to oral ART in those with adherence challenges in a randomized trial. And it has also been shown to suppress those with viremia in several demonstration projects. Again, we have a study that is ongoing, mainly observational, funded by Gates, examining rates of resuppression for people with HIV failing on TLD in Lesotho, Mozambique, Tanzania, and Kenya. And so this will be our comparator as we conduct this trial. Next slide. So this is the hypothesis for the Lancet trial, that in viremic people with HIV on TLD with adherence challenges to oral ART, switching to long-acting ART with long-acting len and long-acting CAB will be superior to continued TLD with adherence support in achieving viral suppression. Next slide. These are the key objectives, again, looking at biologic efficacy, but also looking at safety. Next slide. This is a very busy slide, but this is just the summary of the design of the Lancet trial. We are looking at recruiting 420 participants across Africa, Asia, South Americas, and also Haiti. And we will do a primary analysis at week 48 and also continue follow-up up to week 96. Next slide. Next slide. So I think that's the marathon I had for today. Thank you for listening, and sorry for any glitches. Thank you.
Cissy, thank you so much. That was such a wonderful talk. And an amazing amount of work that's really pushing the field forward. Can I, anyone who has a question, please put it in the Q&A section. It's the button on the bottom of your screen, right next to the share button. And we'll feed your questions to Cissy. Cissy, I was wondering if we could start with, could you comment a little bit in the face of funding cuts likely to PEPFAR, Global Fund, what's the financial implications you see for moving to long-acting treatment?
Thanks for that question. These are difficult times, and in difficult times, you still have to make difficult choices. The first issue about funding is the change in the NIH policies about funding international sites. And this, because this study that I'm talking about, Lancet, is proposed to be funded by dates. And all these sites I'm talking about are international sites. So there are changes right now. We are told by September there will be new mechanisms and methods to fund international sites. And we remain optimistic that this trial will be funded. In terms of access and with PEPFAR, I think most of us don't know the future of PEPFAR, but we are told it will be there. But we don't know how it will be pan out. However, I think in this era when we even expect maybe cuts within PEPFAR, we have to think of interventions that are cost-effective and efficient. And I think one of them is long-acting. So I think we are on the right path right now to provide the data and provide interventions in the treatment in low and middle-income countries that are going to be efficient and also supported, again, by PEPFAR. So we are optimistic, and we know we are on the right path to being able to provide the evidence, because no guidelines will change without evidence. So this is the time to provide evidence to see how interventions in our programs can be supported by PEPFAR, whatever is left of PEPFAR. Yeah.
Thank you. And there was a question from Ken Friedberg. Fantastic talk, Cissy. Thank you. The subject in CARES overwhelmingly preferred CR. Those with viremia are less interested in treatment overall. If when cabotegravir and lenacapavir prove superior, how do you see the implementation of CAB-LEN for people who have adherence challenges?
Thanks for the question. We would have loved, of course, to have a combination with LEN that is as long-acting, but cabotegravir is what we have, and you have to start with what you have. People who have adherence challenges with taking daily pills, I think would be more comfortable with taking injections. We've already seen the satisfaction among patients. There are other studies that the results will be presented at the International AIDS Society of, again, in Sub-Saharan Africa. The study is called Impala, where participants who had adherence challenges were recruited, and they were also given cabotegravir and rilpivirine. This is before we knew that these drugs may not be available to us, but the data will be there. So we will see how this group did. In terms of cabotegravir and rilpivirine, and lenacapavir, I think if we are dealing again with patients who may be non-adherent, we have to think of implementation programs and how do we implement this. One of the ways, of course, we do not remind people to take their pills every day, but we may have to put in place in our programs how we remind patients to come back to the clinic, because the injections are not given exactly at the same time, except at some point. The cabotegravir is given every 2 months, then the nacapavir is given every 6 months. So patients have to come back at least the third time. That's when they would get lenacapavir and cabotegravir together. But in terms of implementation, I think this certainly has to be factored in terms of how do we improve efficiency of the program? How do we remind participants to come? In the CARE study, we showed very high adherence. But this is because this is a study, and we have to make sure that we call participants 1 week before the appointment. If they don't come on the day of the appointment, we again call and find out what happened. In extreme cases, you may have to do home visiting. In program, this is not possible. But how do we remind people to come back to the clinic, especially patients whom we know that we have put in the trial and they are non-adherent? I think also if we implement Lancet, which is mainly CARES was people who were adherent to their treatment. It was a switch trial. Lancet that we propose is participants who are viremic, so they are not very adherent to their treatment. And so within that trial, again, I think there will be lessons to learn. How do we roll this out into program?
Thanks, Cissy. Serena, did you have a comment or a question?
Yes. Cissy, could you also talk about hepatitis B? I know you know a lot about this, so I'm not putting you on the spot. I know that, for example, in CARES, you did both the Hep B surface antigen testing, and then you also test for core antibody. In terms of thinking about the use of long-acting treatments that don't include the tenofovir 3TC component, could you talk about how, as long-acting treatment is scaled up, how you think that could be done with, and whether you think you can just use surface antigen or whether you also need core antibody?
Great question. Sub-Saharan Africa has about 10% prevalence of hepatitis B, so it's fairly common. Most of the participants that we excluded from CARES had surface antigen negative but had core antibodies, so we excluded them. And if you want to generalize long-acting combinations without tenofovir or 3TC, that's a big percentage of patients that you're going to exclude. So this other trial that I was talking about, called Impala, learning from our lessons, they did not exclude those ones with core antibody. They included them. And that was about 10%. No, actually, about 40% of the participants they enrolled. They have now followed up for 12 months. And those participants who had core antibody are doing well. But what they did, they also measured the surface antibody. And for those that had units above 10, they were included. Those had units below 10 meant that they are not protected, so they were not included. I've talked to the Impala PI and the teams on ground. In a public health approach, it is not feasible to go and measure core antibodies and measure surface antibodies. So what we are thinking about, and the discussions will continue, because this situation is different from, for example, the US, is you do a surface antigen and then you exclude people who have a positive surface antigen. You include all the rest. But we also have another long-acting trial in adolescents, children and adolescents. And that trial is called LATA. These children, because we have had national programs providing hepatitis vaccination, most of these are already vaccinated. So maybe it's not such a big deal. But moving forward, because hepatitis B vaccinations are in many national programs, maybe we should vaccinate these adults who may not have had a possibility of being vaccinated and being protected. Because what happened in this Impala study, there were no flares, absolutely none, but there was one new hepatitis infection, one. And so what they have decided to do is vaccinate everybody because they are still continuing to follow them up to week 96. So I think screening for hepatitis surface antigen, which is fairly quick and easy, and then offering vaccination because we have this in our national programs, although this is adults, is something, again, we could be thinking about as we roll out programs.
Thank you, Cissy.
Otherwise, we also looked at all the people we excluded in the cares. We called them back and we did a surface antibody, and we found that over 97% of those had high titers and they could have done very well in the cares. But logistically and feasibility of doing a surface antibody and a core antibody is difficult in a public health approach. Yeah.
Thanks, Cissy.
Cissy, could I ask you another question? I know Ken Freeberg is on, and Ken had the great presentation at CROI showing that if we were to scale up long-acting treatment in the US for patients with viremia, we could have much better outcomes. As you know, we have small programs for patients who are viremic to access long-acting treatment in the US, but they're very small and they haven't really been scaled up to patients with real challenges. Could you give some advice for people who work in the US who have patients in their clinics with viremia and potentially could be using long-acting treatments? From all your experience in Uganda, do you have any suggestions for the US in addition to giving long-acting treatment? What else would you recommend to help patients who have persistent viremia?
I think the situations may be different in the US and Uganda. Absolutely, we do a lot of counseling in Uganda if patients come with viremia. And I don't know whether that is a routine practice, because in our national programs, this is routine. Intensified adherence counseling. But some of the situations, like we saw some presentations also at CROI this year, all are populations that are homeless, and I don't know even how adherence or peer support even helps. But I also presented at the CROI. I made a presentation on PrEP using long-acting and gave what is happening in terms of access in low and middle-income countries. And then I compared with the US. The US, you have the drugs, but accessing them even as practitioners is such a convoluted, long process. Maybe you need to look at it and see how to improve it so that you can have more patients. If we had that access in Uganda, I would have more patients on treatment. But we don't have that access. You have access in the US and you cannot put enough people on treatment because your systems are so complicated. So we know US is complex, but you can simplify things so that you have more of your patients access these, drugs.
Thanks,
So
Cissy.
Serena, you can be the pioneer. You can be the pioneer for simplification.
What about I know you said, Cissy, that scaling up long-acting treatment, we have to be really careful at international sites that doing things like home visits is going to be hard to incorporate into the public health approach. I think this really is going to be globally, as you have this group of patients that really have challenges. Um, do you think how are we gonna do this? Do you think we're gonna have to just use like AI approaches, or do you think there's gonna be those patients that just need the human touch for someone to go and help them? Like Paul Farmer would say, the accompagnateur approach. How do you, I think this probably is our final question because we're almost at the hour, but how do you see, like, do you think there's going to be a possibility of including sort of the human touch and the accompagnateur approach, or do you think it's going to be really hard to scale that up with long-acting treatment?
We have tried to put in our populations and our programs to put the human touch, and we have community volunteers. Of course, they are paid. They are volunteers. They are paid a token to see how to support. There are many, I think, real-world implementation projects in Europe and the US. What lessons can we learn from them? I think they have published some of their work. I know that I've had some of these do like outreach. They take a van and they give injections out in the communities. I think it's different interventions and that may work for this group that don't work for another. I think it is the same way that we sorted out how do we improve access to oral antiretroviral drugs. It was a whole low and middle income countries, they cannot provide antiretroviral drugs. They do not have watches. They can't do it, but we have done it. And maybe we have better adherence than US or Europe or whatever. So I think if you put your mind to it, if you have a problem, you find ways of solving it, isn't it? Yeah.
Thanks, Cissy, for those wise and inspiring words. And thank you so much for the presentation. This is our last Global Health Grand Rounds of the year. So thanks everyone who's been joining us every month. We're going to take a break for two months and we'll be back in September. And Cissy, thank you so much again for joining us today.
Cissy, again,
thank you for inviting me
as well. Yeah. Cissy, you're phenomenal. You're inspiring. And I think you give everybody hope. I know everyone's really having a hard time right now. And, we look to you, Cissy. So thank you for providing this amazing leadership.
We will also be looking to you, Serena, for simplifying US systems. Okay, thank you.
Thank you.
Bye-bye.
Bye-bye.